Hello, Dara.
Hi, Gabriel.
Hi. So thank you for the opportunity to have you on this show today. So this is actually part of my output for HPHR fellowship. So we are meant to have 8 different videos or blogs for any public health topic. So my own is titled "Without Health of Nothing." So I want to talk about how important it is for all of us to actually work towards better healthcare for every one of us across every state in the country. So on this show with you, we'll be actually talking about health insurance, the state of insurance in the country, and what can be done differently. So now, before I delve into the questions, can you kind of introduce yourself?
Okay, thanks for having me on the show, and congrats on your work with the Harvard Public Health Review. My name is Dara Ajala-Damisa. I'm a program manager at Nigeria Health Watch. Yeah.
All right, thank you. So what's the current states of health insurance in the country? That's how you describe health insurance in Nigeria.
Okay, that's a complex question that lots of panel discussions, policy dialogues have sought to address. But summarily, suffice it to say that over the last couple of years in Nigeria, there's been increased discourse and action towards health insurance across states in Nigeria. The space before 2014 was one which saw the National Health Insurance Scheme as one of the sole providers of health insurance in the country. There were private health insurance organizations and also individual organizations providing some form of health insurance for their employees, but largely the burden of providing health insurance rested on the National Health Insurance Scheme.
Okay.
Due to different reasons, different challenges and hurdles, that didn't work quite as well. As for over 12 years, the health insurance scheme was not able to cover up to 1% of Nigeria. Fast-tracked to the signing and implementing of the National Health Act, which also saw as a subset the setting up of state health insurance schemes. Within the next 2-3 years, we saw that many states started with some level of progress and challenges. They started to draft their health insurance bills into law. This was supported by, in some way, by the formulation of what is called the Basic Healthcare Provision Fund. Yeah, exactly. So that fund, though not directly tied to it, but had some input. So 50% of the Basic Healthcare Provision Fund was supposed to go to the National Health Insurance Scheme. And somehow the National Health Insurance Scheme tied it to states developing and drafting their own health insurance laws. So that kind of spurred many states across the country to start to draft, sign, and set up their health insurance laws and agencies. So across the country, almost every state now has their health insurance laws signed. I think it's just say 1 or 2 states that don't have it implemented, but every state has drafted it. Some states have had to take it back to their house assemblies to do some form of reviews, but every state pretty much has drafted their bills. Now implementation, that's where the differences comes across different states. Some states have started to actively enroll, but many states are still embroiled in the operational challenge of moving from policy to practice. That's moving from a drafted bill to actually beginning to enroll lives. Some states, I know I'm jumping ahead, some states such as Delta have started to have been enrolling lives since 2019, I believe. They have enrolled over 1 million lives, which is a very good percentage of what the NHIS had done nationally across the space of 12 years. So that's some progress in the state. So that's basically the overview of health insurance in the states. There has been a pause, and then in recent years, it's a big push via the state health insurance schemes. Yeah.
Right, thank you very much. Now, we've talked about the policy, then action, yeah. But what is actually preventing people, the optic now, from people's perspective now? What is preventing, the optic is not there. Yes, policy is there, bigger than part in some states. Then some states are actually working. But what is actually what are the limitations preventing people from getting themselves insured?
Okay, many people like to say that there is no willingness in communities. We need to increase awareness and willingness. But I beg to disagree slightly. I beg to put some pushback slightly, because in 2018 we did what we call the willingness to pay for health insurance study in Benue State. First of all, the results were quite shocking, because first of all, people were not only, once they knew what health insurance meant, people were not only willing to pay for health insurance for themselves, they were also willing to pay for other family members, which is what's this called now, which is anyway, moving on. They were basically willing to pay for health insurance for their family members. So I wouldn't say that the challenges lie with the people. I think that if we set up effective systems that work consistently, we won't have an issue with uptake. Once the systems are working, you just need to ramp up a lot of community engagement, community awareness, for people to understand that this is not just another government scheme that is here to steal your money. Because there is also that issue. We encountered that issue across the work that we had done with communities, increasing awareness for health insurance. There is that big issue of trust. A lot of schemes, especially the National Health Insurance Scheme, a lot of schemes had come under the guise of health insurance, telling them that, so those schemes hadn't delivered what they promised. So there is that issue of trust, and trust can be mitigated when effective systems are put in place consistently, because the people are your biggest marketers. We wrote an article. So I wrote an article sometime in 2019 about utilizing community marketers for help. The people are the biggest marketers for help. Once the community sees that something is working, they will take the word themselves to other family members, because nobody wants to keep something effective to themselves. So I think that the biggest challenge limiting health insurance in the country is the setup of strong, effective and consistent health insurance schemes. You can't have a system that is going to work. You can't promise heaven and earth and say you give free care to everybody in the state, and then it works for 1 year, and after 1 year it stops working. No, the system has to be consistent, otherwise trust will be eroded.
Yeah, thank you very much for that. Okay, so moving ahead now, so can you kind of give us some solutions we have, some innovations, some organizations that are actually doing things differently, to actually make sure that people are insured in the country?
Yeah, absolutely. So I did mention the Delta State Health Insurance Commission. That is one organization that seems to be doing things pretty differently, and their results, I can speak for it. They have managed to enroll quite a number of citizens of the state, and really quickly too. They managed to set up an institutionalized a local IT system that is able to address the needs of the people and eliminate delays, eliminate challenges with enrollment and uptake. All these delays that come when a system is not, that this system doesn't utilize technology. Yeah, so they managed to do that, and I think that that's something that lessons can be learned from. If you speak to them, though, they would always tell you, the team at the Delta State Commission, they will always tell you that you can learn, but you need to domesticate. So that's something that to be kept in mind. Across the country, I think what has worked, solutions that have worked, are solutions who have learned from other succeeding solutions, but have also domesticated it, have also contextualized understood their local problems, understood local challenges, and developed solutions that deliberately speak to those problems. Yeah.
All right, thank you very much on that. So now to make this a thought leadership, to give a thought leadership approach to this now. So what are your recommendations now for? I mean, you talked about health systems, you talked about community engagement and awareness. So what do you think can be done differently? Like, what's your recommendations so that at least people watching now can at least learn this?
Okay. I mentioned community. As you will tell, I'm big on the community. There's something that Rwanda does called the community-based health insurance scheme. The community-based health insurance model has seen a lot of pushbacks in that it seems to have worked for Rwanda, but there are a lot of limitations in the sense that you cannot, when you talk about health insurance, one of the biggest factors are pooling, risk pooling, and community-based health insurance scheme, by the way it's structured, basically limits the pool, and the pool that it gets are those. There's a lot of adverse selection in the pool of community-based health insurance schemes. So only those who are sicker and those who are not able to pay are those largely who sign on to community-based health insurance schemes, making it such that many community-based health insurance schemes have started and failed, also contributing to the trust issue we talked about. However, I always advocate that we shouldn't throw the baby out with the bathwater. There is a very unique role that community plays in increasing uptake for health insurance, especially in Nigeria that is strongly community focused and that has a lot of mistrust in government. So my proposal, my recommendation is this. While understanding the challenges with community-based health insurance schemes and the adverse effect of the risk pooling involved in community-based health insurance scheme, we can utilize community members, community groups as marketers for the broader pool of enrollees. Now, you don't necessarily need to have a different pool for people in this community, but you can have them as marketers.
From the same community.
Exactly, from the community. You have marketers and groups in a community such that people in the community do not necessarily need to know or go to the state or national health insurance scheme, but rather they know this community people. So a group, for example, Market Women's Group, for example, they know that this is who they are paying their money to. However, this group is remitting to the state or national health insurance scheme. You're removing the adverse effect of community risk pooling while leveraging on the impact, on the very, very unique role that community groups and community members play in the community. So this is my strong recommendations, because a large percentage of people in Nigeria, 70% as a last report, are in the informal sector. A large percentage of people pay out of pocket. And from this number, the numbers are really dire. People are paying out of their nose for healthcare. People are being thrown into abject poverty because of simple cases of health, simple health events, simple as malaria. Someone will be thrown into abject poverty, having to withdraw their child from school and all of that. These things can be mitigated with effective community mobilization. So this continues to be my strong recommendation. We can use the community to market for universal health coverage. Yeah.
Thank you very much. I like that note. Can use community mobilization to market for universal health coverage, and that's actually very important, because I don't think there's actually any universal health coverage without good health insurance, especially in a country like our own, where we have a lot of people that their peanuts or their pockets for healthcare. So health insurance actually helps to solve a lot of problems, especially at the primary healthcare level, where just simple diseases like malaria, typhoid, that some people even take those kind of diseases to be tertiary level, because we don't even have functional primary healthcare. So health insurance will help a lot. Thank you very much for your time. I'm grateful for this opportunity.
Thank you so much.
That'll be all. Bye.
Right.